And today, this is topic is ICU management of severe sepsis and septic shock for the nurses. I'm happy to announce that today's session is taken by Dr. Saif, who is an assistant professor in Department of Critical Care Medicine, Ranchi, Jharkhand, and he's having immense interest in the critical care, many publications, and many almost more than 30 publications are there, and his area of interest is sepsis, hemodynamic monitoring, and vascular access, including critical care ultrasound. I welcome Dr. Mohd Saif Khan. Kindly take the dice and go ahead. Thank you.
Thank you so much for the warm welcome, Dr. Joshi. And it is a pleasure for me to speaking on this platform, especially for the critical care nurses who are at the upfront of the critical care medicine delivery all over the world, particularly in India, in the second pandemic of COVID. We understand your involvement. So this is the, I think, third lecture in the series of next in the nursing academics. And the topic is sepsis and septic shock. So you all know that sepsis and septic shock is a medical emergencies like acute myocardial infarction, stroke, poisoning, diabetic emergencies, hypertensive emergencies, etc. So sepsis and septic shock is also a medical emergency. It means that we have to act very fast, because if we don't act fast, the mortality is very high, as you know. So the key to successful sepsis management is the rapid detection, that is early detection as soon as possible, and to start the treatment. And following the treatment, we have to go and assess continuously the patient for the progression or deterioration. Okay, so that is very, very important that we diagnose the sepsis early. So content of my talk will include the definition of sepsis and septic shock, what are the current management guidelines, what should be the nursing assessment of sepsis and septic shock, what parameters and how to monitor them, and what interventions are needed during the resuscitation, and what are the main nursing issues post-resuscitation. So all these points I'm going to cover in my talk one by one. So whenever you come across a patient who is developing sepsis in ICU, emergency department, or in the ward, you have to be on your toes. You have to be very, very cautious, as well as you have to be having high index of suspicion that this patient might have sepsis, because if you can detect in time, as I said, the outcome will be good. So this was the MCQ which I had delivered before my talk, and I wanted all of you to complete it. So the definition of sepsis in this MCQ I asked. So let's discuss about the definition first. So according to the latest publication, latest definition, that is called sepsis 3 definition. Now, this is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. What does that mean? That means that sepsis causes organ dysfunction. So this organ dysfunction has to be life-threatening, and it is because of a dysregulated host response to infection. So there are three terms which are very, very important: life-threatening organ dysfunction, like respiratory system involvement, cardiac system, cardiovascular involvement, CNS involvement, GI involvement, kidney involvement. All these involvement are there in the sepsis. Okay, and this dysfunction is because of, and this involvement of organs is because of a dysregulated or uncontrolled host response to a suspected or confirmed infection in the body. And we know that what are those infections? It may be anywhere in the body, isn't it? It can be in the lungs, which is the most common site of infection. The focus of infection you have to be keeping in mind while defining or detecting the sepsis in a patient. So as I said, lung. So that could be pneumonia. Okay, that could lead to, this is the most common cause. The bacterial pneumonia, community acquired pneumonia can lead to the sepsis most commonly, most often. Then it could be the urinary system, UTI. It could be the blood itself, that is bloodstream infection because of lines we place, like central line, the peripheral line. Even arterial line can cause infection. The CNS infection, meningoencephalitis. Then there are so many and so forth, kind of foci of infection which can lead to the sepsis. So the three criteria should be there to define the sepsis. One is the life-threatening organ dysfunction should be present, which should be because of dysregulated host response to an infection. That is third thing. So how can we define or how can we score organ dysfunction? So organ dysfunction may be a just subjective thing, but basically it is based on a score that is known as SOFA score, sequential organ failure assessment score. So this is a this score was developed way back in 1996 by European scientists, and they came up with 6 organs, and they gave the scores to the organ dysfunction like cardiovascular system, central nervous system, respiratory, coagulation, liver, kidney. And the minimum score is 0, the maximum score is 24. And if the score is more than 12, the mortality is more than 50%. That is what the score is about. So defining the severity of organ dysfunction and severity of illness overall. So if the score, the SOFA score increases by 2 points, that means that there is a life-threatening organ dysfunction. Okay. So that SOFA score you can calculate on an app in your mobile phone as well. It is not so difficult to calculate. But now we have quick SOFA because some people still have difficulty in calculating a classical SOFA score. So now we have quick SOFA after 2016, and that is based on the 3 criteria only. Look at the brain, look at the respiratory system, and look at the cardiovascular system. Only 3 systems, and that is quite clinical. So just look at the patient, whether the patient has altered mental status, GCS, that is Glasgow Coma Scale, less than 15. So that is 1 mark, 1 score. Second is respiratory rate. If it is more than 22, patient is having tachypnea, and that is score, again 1. Then the low blood pressure, low systolic blood pressure, less than 100 millimeter of mercury is also 1 more score. So if the score is more than 2 or 2 or 3, then there is a high risk of poor outcome, and probably you can say that this patient may have a sepsis, provided there is a focus of infection. So after defining the sepsis or detecting the sepsis, you must also understand that these patients will progress to septic shock. The subset of the patient who have sepsis can progress to septic shock in no time if you don't intervene. And it is defined as the sepsis with the persistent hypotension despite the adequate fluid resuscitation. Matlab कि आपने you have given a fluid for a hypotension, but still there is a persisting hypotension, and that is requiring the vasopressor support to maintain the mean arterial pressure more than 65 millimeter of mercury, and also a serum lactate level more than 2 millimole per liter. So there are 2 things to define the septic shock. It should be a fluid refractory, a fluid resistant hypotension requiring a vasopressor. That is 1. And second, the high lactate. High lactate means that there is a problem with the tissue perfusion. The blood flow to the organs, to the tissues is decreased. And that is because of that, what happens? There is increase in the anaerobic metabolism. Aerobic metabolism switches to anaerobic metabolism, and that causes increase in the lactate level in the blood. And if this lactate level is more than 2 millimole per liter or 18 milligram per deciliter, that means that patient has probably the signs of, the definite sign of hypoperfusion. So after defining the sepsis and septic shock in the ward or in ICU or in the emergency department, you have to initiate the treatment fast. And for that, we have a guideline, and that is known as classically Surviving Sepsis Campaign Guideline, and this guideline gave the the management principles in 2004, and later it was updated in 2008 and 12 and 16. So this is the 4th update, and again there was a sub update in 2018, which gave 1 hour bundle. So according to this guideline, so first we will look at, because this is an interactive session, so I will discuss in the form of MCQ. So this is an MCQ in front of you guys. The patient's blood pressure is 72 by 56 millimeter mercury, heart rate 136, tachycardia, respiration 24, there is tachypnea because the RR is more than 22. The patient has a fungal infection in the lungs. The patient also has a fever, warm, flushed skin, and is restless. You notify the physician as a nurse and who suspects the septic shock. You anticipate that the physician will order the treatment. But what treatment first? So these are the choices: the norepinephrine, crystalloid fluid, IV steroid, or antibiotics. So what should be the first priority treatment? So answer. So let's discuss it first. So answer, it will be clear in the discussion. So this is the guideline which I was talking about, the Surviving Sepsis Campaign Guideline, published in 2016 in Intensive Care Medicine as well as in JAMA, Journal of American Medical Association. And in this guideline, they have given the whole critical care of the patient. The patient enters to ICU, you do so many things. So you have to treat a sepsis, and as well as apart from sepsis, you have to take care of the patient, in other aspects also. Okay, so all these things have been given beautifully in these detailed guidelines. I'm going to take only the resuscitation part. So there is another question: a patient who is post-op kidney transplant has developed septic shock. Which statement below best reflects the intervention you will perform for this patient? Okay, this is a post-op kidney transplant patient has developed septic shock. What will you do? So whether you will start a fluid resuscitation and NORAD infusion, or collect the culture and administer antibiotics, measure the lactate and start fluid resuscitation, or insert a central line and start vasopressor infusion. So any option may be correct, but which one is the most appropriate and best reflects the intervention we will discuss. So this slide is the answer of previous two questions. So R1 bundle. So previously, when the Surviving Sepsis Campaign Guideline was launched, we had 6 hours bundle and 24 hours maintenance bundle. So resuscitation and maintenance bundles. Then later they thought that it's too cumbersome to follow all those things in the bundle. So they simplified later to just 3-hour and 6-hour bundle. Later they simplified it more in 2018, and now they came up with only 1-hour bundle to intensify the treatment aspects in septic shock, to save more and more lives, because the delay is very, very fatal. These are 5 points you should always remember. Okay, these should not be missed. You just remember. So first of all, measure lactate. So as soon as patient comes, you put an IV line and take some blood for the investigation, routine investigation, as well as send for blood gas, and in which you can get a lactate level. After lactate level, do the blood culture and start antibiotics. Antibiotics have to be given within 1 hour. If it is taking time for the blood culture, you administer the antibiotics. Don't wait for the cultures, okay? Because antibiotics are the key treatment for sepsis and septic shock. So never delay antibiotic. So antibiotics should be broad spectrum and empirical initially, based on host factors and focus of infection and other characteristics. Then you start a fluid resuscitation, that is 4th point, with a 30 ml per kg crystalloid fluid for hypotension, or if the lactate is more than 4 millimole per liter. Okay, so this is important. So if you see that patient is having hypotension, that is defined as mean arterial pressure less than 65 millimeter of mercury, or SBP less than 90 millimeter of mercury, then you start the fluid resuscitation with a 30 ml per kg crystalloid solution. Crystalloid can be Wenger lactate or normal saline, whatever. And the choice depends on the patient's condition, but anything initially you can start. That won't harm the patient. Anything, NS or RL, but some people say RL will be better, but that's their choice. But anything you can start So you give at least, so 30 into 50, suppose patient is 50 kg, you give 1.5 liter. Or if the patient is 60 kg, you give 1.8 or 2 liter of the fluid. Okay. So that will be like a fluid challenge that is going to raise the blood pressure. If the heart is going to respond to this fluid challenge, it will respond and the blood pressure will pick up without any vasopressor. And that will be there for longer time, at least for 1 or 2 hours. Okay, then again it will drop. So you have to monitor also very well. And you start remeasuring the lactate. If the lactate initially is more than 4, you start the fluid. Again, you measure the lactate after the fluid resuscitation and see if it is decreasing. That is very, very important. So lactate, you must repeat, remeasure again and again. And if the patient is not responding to the fluid, that means if the blood pressure is not picking up, the mean arterial pressure is still less than 65 millimeter of mercury, or the lactate is still high, then you start the vasopressor to improve the perfusion to the tissue. Now, this is another question. As per surviving sepsis campaign guideline, patients should receive antibiotics within. So I have answered this question already. But here there are so many confusing things. Whether the timing should be 6 hours of ICU admission, or 1 hour of detection of sepsis, or 1 hour of emergency department admission, or 1 hour of onset of hypotension. So this is quite tricky. So remember, so it is 1 hour definitely, but whether it should be detection of sepsis or emergency department admission or onset of hypotension. So these last three options, any option may be correct. So this slide is the answer. So same 1 hour bundle, but it is very sequentially given, and good pictorial diagram I have taken from the Society of Critical Care Medicine, sccm.org website. Okay. So sepsis or septic shock is a medical emergency, as I said. Initiate the bundle after recognition of sepsis or septic shock. As soon as you diagnose, you detect the sepsis, you should start the bundle. Okay, so that is the answer. After onset of sepsis, you start, that is time 0. You start counting the time, and within 1 hour, you should be able to inject the antibiotic. That is very, very important. As I said, the antibiotic is the key treatment, is the specific definitive treatment for sepsis and septic shock. And any other thing which you are doing for the patient is the secondary, but antibiotic is the first and foremost important thing. And definitely, if you could take the blood culture in time within 1 hour, that's well and good. If it is delaying, then please do not delay the antibiotic administration. Okay. Now, what is this sepsis 6? So it is quite popular in nursing. Okay, and in UK. In UK nursing practice, they will ask definitely the sepsis 6. What is that? It's very simple thing. They have created box and trolley based on the sepsis 6 checklist, or this kind of bundle. So sepsis 6 bundle. So in this bundle, there are 6 components. So you start oxygen first with the face mask as soon as patient arrives. Okay, and keep the saturation more than 94%. Then you take the blood culture, start antibiotic, give fluid, challenge, measure lactate, measure urine output. Okay, so this is what they are following in UK, but not all over the world. In India, we don't follow this. We follow the R1 bundle. We follow the surviving sepsis campaign. Okay, but you should also keep this thing in mind. Only one point I can say over here is good is oxygen. You can start oxygen definitely as soon as the patient comes to ICU and the patient is desaturating, definitely that you are going to do first. Okay, but remember that the lactate, blood culture, antibiotic, fluid are same. Urine output, previously in the 6R bundle, there was the urine output and CVP, central venous pressure monitoring, early goal directed therapy concept was there, but now they say the evidence is not so good for the early goal directed therapy. Okay, so now we don't chase the urine output and we don't chase the CVP. So previously the people used to keep the CVP more than 8, between 8 to 12 millimeter of mercury. Now those concepts are fading off. Currently According to the Surviving Sepsis Campaign guideline, we should not be using the static parameter of fluid responsiveness. So all those things I'm not going to tell over because I want to keep the things very simple for the sisters over here, for the nurses. So just remember this, but don't forget the R1 bundle. So this is what they follow in UK. So they keep a sepsis box and sepsis trolley. But that is good, which we can adopt. If I'm not sure if in the private hospital we are doing that, but in Tata Memorial Center, where I had completed my degree in critical care, we used to keep a sort of a few vials of antibiotic for the stat. There were a thing called stat orders. So we used to keep all important antibiotics vials, and as soon as the antibiotics were decided and the patient goes to septic shock, we used to give antibiotic. Okay, even in night, any odd hours of the night or day, and that saved a lot of patients. We used to keep the culture bottle also is extra in the ICU, so that is another thing. And obviously we had the EBG machine and like any other ICU. So I think these two things are important. But in the peripheries, in the peripheral hospital, where the facilities are not so standard, at least you can keep a bag in which all important things should be there. The vials of antibiotic, blood culture bottle, a few wax of IV fluid, normal saline or oral, and you can keep a hydrocortisone that is also having a role. You can keep few vials of few ampules of noradrenaline and adrenaline, few syringes, needles, IV sets, and all these things are going to be there in their sepsis bag or sepsis box, especially in peripheral hospital. It is very good because it will cut short the time to start the treatment. So as I said, in sepsis and septic shock, the time is important. If you delay, you are not going to save the patient and outcome will be very bad. Now another question. A patient in septic shock receives large amount of IV fluids, large amount. However, this was unsuccessful in maintaining tissue perfusion. As the nurse, you would anticipate the physician to order what next? IV hydrocortisone, noradrenaline infusion, albumin 20%, or dobutamine. So I think this has been covered already in 1 hour bundle. So if patient is not able to maintain the tissue perfusion, that is lactate, or mean arterial pressure more than 65, despite the large amount of IV fluids, the next choice should be vasopressor, noradrenaline. Okay, but if the patient is not able to maintain the blood pressure, that is mean arterial pressure, despite the vasopressor high dose, then definitely you should think of hydrocortisone. That is recommended if the patient is having the fluid resistant vasopressor resistant hypotension. Okay, so in that case, the dose is 200 mg per day, that is 50 milligram QID, or you can give IV infusion, that is 200 mg. You load in a 50 ml of syringe and start at 2.1 ml per hour. So that you can do. Okay. Another question. A patient in septic shock is experiencing hyperglycemia. Okay, so that is very usual if the patient is having sepsis or patient is having any other condition like diabetes, so patient may develop hyperglycemia. That is due to the stress-induced hyperglycemia. And you have to start insulin to keep the sugar under control. So what is your target sugar? So that is also important to know. And I'm sure you must be following in your ICU. So what is target? So target is very close to 200, less than 200 or less than 180. So now we go for a non-tight control. So the answer is less than 180 milligram per deciliter. So in this surviving sepsis campaign guideline, they suggest that we should be monitoring the blood sugar every 1 or 2 hours, and capillary blood is good way. Okay, is good way, but it is not so accurate. So accurate one will be the arterial blood gas. If your patient is having hypotension, persistent and requiring vasopressor, what are you going to do? You are going to put a central line and you are going to put an arterial line. Okay, through arterial line, if you do a blood glucose, that is the most accurate. Arterial line blood glucose is the most accurate compared to capillary blood or compared to the venous blood. Okay, so follow that. In our standard in a corporate hospitals, we follow the arterial blood gas sugar monitoring, arterial blood sugar monitoring. Now your patient is receiving aggressive treatment for septic shock. Which findings demonstrate treatment is not being successful? So that is good question. Okay. Whether the serum lactate is 1.8 is a good sign or bad sign. Urine output is 50 ml per hour. Heart rate is 129 per minute. Mean arterial pressure is 55 millimeter of mercury. So which one is the bad sign that patient is not responding? So lactate is less than 2 is good. Urine output is good because it is okay, more than 30 ml per hour. Heart rate is 129 per minute, that is tachycardia, but that is not the criteria to say that patient is responding or not responding. The heart rate is very insensitive thing. So this is just a mean arterial pressure, which is the answer over here. The mean arterial pressure should be more than 65 millimeter of mercury. Okay, but that is again, this option is also not correct. If we talk about the latest evidence, 65 trial, so they say even 55 is good if the lactate is normal. So, but still, according to the sepsis, surviving sepsis guideline, we take 65 as the cutoff. If the question comes, or a question asked in interview, or if you want to just remember, at least remember 65. Okay, for a normal individual, not hypertensive, not elderly population. But if the patient is having the chronic hypertension or elderly, then you have to keep the mean arterial target pressure target a little bit higher, at least 75 or 80 millimeter of mercury. Now this is the interesting part. What should be nursing assessment of a sepsis or septic shock patient, and what parameters and how to monitor them? So this is simple. So see, you have to monitor few things in a patient in whom you have given the treatment, resuscitation, antibiotics, etc. So you have to see whether the patient is resolving fever. The fever is coming down. Oliguria is settling. Tachycardia is settling. Respiratory has become better. Oxygenation has become better. Blood pressure is picking up. And ventilation is now better. The peripheries are now, if they are cold peripheries, now becoming warmer. But in septic shock, the peripheries are always warmer until unless there is a heart involvement. So by looking at periphery, we cannot see. So only these 6-7 things are there by which we can say that the patient is responding or not. And also the lactate. Lactate is very important. If the lactate is coming down, suppose the initial lactate is 6 or 8, and you give the fluid, you started vasopressor, you gave the antibiotic, and after 24 hours, if your lactate has come down to more than 50%, no. So from 8 to less than 4, it means the patient is going to be safe. And there is no continued focus of sepsis in the body. So you have taken care of septic focus very well. Sometimes it is not possible. Sometimes antibiotics are not able to cover the focus. So what you have to go for? You have to go for the source reduction. So you have to take care of the focus of infection. So what is the focus of infection? Suppose there is a line which is infected, central line is infected, or there is an implant, orthopedic implant or pacemaker, or any implant which is looking the suspected source of sepsis, that has to be removed. Or if there is an abscess inside the body, that has to be detected by ultrasound or CT scan, and that has to be evacuated by surgical mean or interventional radiology. So that focus of infection is very important to be taken care of. And simply by giving just antibiotic, you can buy some time. But if the focus is very big, okay, then probably you have to go for the radical means to evacuate that focus of infection. Okay, that is very, very important. For example, in a case of meningitis, suppose the VP shunt is blocked, and that causes continued showering of infectious emboli. and patient is having bouts of sepsis again and again, then probably you have to think of to remove the VP shunt. Okay, so always keep in mind the focus of infection has to be eradicated as soon as possible. Otherwise, you will lose the patient. What interventions are needed during resuscitation? So definitely, the patient who becomes sepsis or septic shock, you have to take care of so many things at a time. That's why you require a lot of people, and that's teamwork. Okay, so every individual has to should know that what has to be done. So doctor has to know, yes, this is my job. I have to put a few lines, put intubation, tracheal intubation. The nurse should know that, yes, I have to secure IV line, draw the blood culture, investigations, and start the antibiotic as soon as possible. The pharmacist, in few hospital, pharmacist also is important to take care of the drugs and drug interaction. Then other rotating nurses will be helping, the ward boy will be helping the doctors and nurses. So it is a kind of teamwork. Okay. Then next day, the consultant come for round and formulate a plan for sepsis and septic shock. So that has to be, those orders have to be followed. So all these things are important. So there are a lot of interventions which we perform during management of sepsis and septic shock, and we have to be very quick in performing these interventions during resuscitation, otherwise patient will not have a good outcome. And we have to always monitor the blood pressure, mean arterial pressure. The correct way of doing that is putting an arterial cannula and start the intra-arterial blood pressure, if it is possible. I know in few places it is not possible, so you have to depend on NIBP, non-invasive blood pressure, cuff blood pressure monitoring. So that's okay. Then lactate measurement, as I said, you have to do it every, you can say, you have done initially, then you have to do after 1 hour or so, then at 6 hours, then at 12th hour, then at 24 hours, because that will give you the idea that whether the patient is improving or whether the patient is deteriorating, and you have to probably change your plan of treatment. Then urine output has to be monitored, putting a catheter, urinary Foley's catheter inside, and start putting a urometer and then measuring it properly, and that has to be more than 1 ml per kg per hour to say that your management is successful. Then RBS monitoring, like that. Then other parts like thromboprophylaxis. So these patients may develop thrombus, clots inside the teeth pins of legs, and that clot may travel all the way to the lungs and can give rise to pulmonary embolism. So thromboprophylaxis is very, very important. You have to put a stocking and then start the heparins. The sugar management and insulin protocol, as I said, and the most important, never forget enteral feeding. So as soon as your blood pressure is rising, you start rising, then you think of enteral feeding. If the patient can take orally, you start oral nutrition. Otherwise, you can put a rice tube and start enteral feeding. Okay, within 24 to 48 hours of admission to ICU. So I'm not going to talk about enteral nutrition in this lecture, definitely. So that will be a different, totally different topic. So I think I've covered most of the point related to sepsis and septic shock. Remember that critical care nurse should be able to recognize the sepsis and assist in the managing the patient with sepsis along with the doctor. So your part is very, very important as a nurse. You can at least tell the doctor that, oh, this patient has sepsis. You can raise a alarm, you can ring a bell. Sometimes doctors are very busy, so you have to detect it. This is also your joint duty to recognize the sepsis, and that is how you will be able to save a patient. Antibiotics is a key management of sepsis. As I said, it is a specific part of management, and therefore never delay its administration. Follow 1 hour sepsis bundle, as I said, for the successful management of sepsis septic shock, and as I said, teamwork is paramount to the success of sepsis management. Thank you so much.
Thank you, Dr. Saif. It's just so nice, and I should appreciate that it's a easy language so that everybody can understand very well. Uh,
Thank you.
your chat box, if I can see that one Dimple Suneja, she wanted to ask you, sir, after resuscitation, can we give the enteral feeding?
Dr.
That's a
Saif,
good
just
question.
sorry to interrupt, but if you can just stop sharing screen so that people can
Oh, stop
you and
sharing.
Dr. Joshi.
Yeah, I will stop sharing now. Is that okay?
Yeah, that's fine, sir.
Oh. Yeah, so answer to the question about post resuscitation, can we start the feeding? Yes, why not? We can start the feeding slowly. If the patient's consciousness is good, the patient is able to maintain the reflexes, airway reflexes, definitely we can start the feeding. But obviously we have to ask the doctor first. If your doctor's orders say yes, you can start, we can start all. If the patient is intubated and is maintaining the blood pressure, definitely also we can start the feeding, but you can wait for 24 to 48 hours, but not beyond 48 hours. Okay.
So another query from the audience, I should say, what is the role of steroid in sepsis? They wanted to know why we use the steroids.
Why do we use the steroid? So that I probably have not explained why. So see, in sepsis, what happens, it is a stressful response. And whenever there is a stress in the life, I mean, it is a fight or flight reaction. What hormone is secreted from the adrenal gland? It is a stress hormone. So it is a steroid. So extra steroid will be secreted from the adrenal gland during the period of stress. But that extra amount during the sepsis is not secreted, or it is under secreted in some times. So we have to give little bit extra, extra amount externally. So that is the significance. So there is a relative deficiency of steroid in sepsis and septic shock. If the patient is not able to maintain the blood pressure despite the fluid and despite the vasopressor, we have to give steroid in such condition to replenish the deficiency of the steroid, which actually had to be secreted by the adrenal gland. Thank you.
Dr. Nidha Naik, you can ask your question. Dr. Nidha Naik, you raise the hand. You can ask your question. Dr. Medha is there? Is able to listen? Okay, so next I'm inviting Nazim to ask the question.
Yeah.
Nazim, you can unmute and ask your question. Okay, so I'll come to the other thing, queries. In fact, one of the audience is having the query, what about adding second vasopressor?
Yeah, that's a good question. So if the patient is not responding to the noradrenaline, which is the vasopressor of choice, okay, the dose is 1 microgram per kg per minute. If the patient is not able to maintain the mean arterial pressure more than 65, then we have to add a second vasopressor. So second vasopressor can be vasopressin, okay, that is the fixed dose vasopressin, or can be, if the vasopressin is not available, you can also use epinephrine, okay, that is also very useful. So I think this is about the second vasopressor, either vasopressin or epinephrine. But you have to look at the tachycardia. If the patient is having tachycardia so much, then probably epinephrine is not a good choice. Still, you have to go for a vasopressin.
Okay, I think one of the audience is having a little confusion about the feeding part. So he asked, according to aspirin guidelines, one can wait for 7 days before starting feed. If a person is well built, then why wait for only 48 hours?
No, is there really a guideline for to wait for 7 days? I don't think so.
I
We should not
so
wait for
I
so much time. Hey, see, let me
I
explain you only. Can I explain a little bit about it? So if it is there, suppose if it is there for 7 days, still we should not wait. Why? Because if you are not using the gut, if you are not using the gut, and if it is the gut is unused, the gut epithelium, okay, anthrocytes will become atrophy. Okay, and there are chances that uh, there are chances of translocation from the gut, the organism, because gut contains organism, bowel contains so many organisms, okay, even candida. So those organisms will gain access to the blood, okay, and then it will increase the infectious complication more and more, the resistant one. So definitely you should use the gut, at least start a trickle feed, it's trophic feed, okay, very low dose feed, to just maintain the integrity of the health of the gut epithelium. Otherwise, so it is not just for the nutrition only, overall body nutrition, it is also for the health of the gut.
in this I just wanted to add that anybody is having the well built, it doesn't define that it is nourished, malnourished, or well built. So this is like a very thin line between that well built, because we have a many nutrition lecture also in the series. I think in the future also we will present. So that shows that somebody who is having a lot of weight, or somebody who is having a very thin build, but they cannot be well nourished. They cannot be well nourished, they may be malnourished also. So that is not only the criteria. And in sepsis, otherwise also, at the nursing point of view, I just wanted to add that if you wait for 7 days, I don't think the patient will survive for our feeding to wait for. So it's not a good idea. Like we will definitely discuss about that, like where you find out this guidelines. But definitely within 24 to 48 hours, if you start that, like Dr. Saif also told, it is going to help only, and we should start. In fact, and we should promote RT feeding. And many misconceptions that RT aspiration is that 25 ml, 30 ml, then we should stop. So these all things also should be obsolete, and as soon as possible we should start the feeding. Okay. Now another question is from Vanaja, I believe. The procalcitonin and lactate, or BNP, pro BNP, also using as a biomarker in sepsis.
Yeah. So definitely, so I'm not talking about the. I didn't know that the nurses are so intelligent, and now they are following so many things. Great. I am very impressed by the question. So yes, there are so many biomarkers of sepsis, and in which the procalcitonin is the first and foremost. We can use CRP as well nowadays, but procalcitonin is the very specific marker. If it is very high, definitely there could be infectious process going on, and antibiotics has to be started. But the role of procalcitonin is more in stopping or de-escalating the antibiotic rather than just starting the antibiotic. Okay, so this is a very good biomarker, but it should be used to stop the antibiotic or to de-escalate the antibiotic. And regarding the BNP is not it is not a biomarker of sepsis. It is biomarker rather of cardiac failure, cardiac biomarker. Okay, so we should not talk about this here. And lactate is a biomarker of, again, a perfusion. Of it is a CVS biomarker. If the lactate is high, it means the perfusion is not well. Another biomarker is there, not marker. It is a parameter which we use, SCVO2. SCVO2 is central venous oxygen saturation. You can also use this parameter and keep more than 65% as a guidance to your treatment, to your resuscitation. Thank you.
Just wanted to add for the benefit of the audience that when we're talking about the PCT or procalcitonin, don't just go for one single test. Like if you do the day one PCT and you find that he is 3, and then you started the antibiotics. Now after 72 hours, again go for the PCT. That is to check that like whether our antibiotics are working or not, or to just to judge that like whether our path is right or not. And if the procalcitonin is in increasing trend, then you need to check your blood cultures reports, and accordingly you need to escalate the antibiotics also. Same way, if your precalcitonin is good, you already are given the antibiotics for 5 to 7 days. Now this is the time to de-escalate the antibiotics also. We are not in habit of de-escalating the antibiotics, and ultimately in the long term it may cause fungal infection or antibiotic resistance also. So keeping this thing in mind, that PCT is to be used to see the trend instead of just using as a biomarker for the single time. And pro BNP, and that is to whether the patient is having the cardiac issue or some other issue. So that is to differentiate that. So that is not a bad marker for assessing that whether the patient is having the cardiac issue or not, but not directly per se for the sepsis, as Dr. Saif already told. Dr. Saif, now next question is that I think the audience is good actually. CPK is one of the sepsis bundle. Is there CPK is there in any of the sepsis bundle? They ask.
I don't think so. Sorry if you have read somewhere, but it is not a part. I mean, it will not going to be of so much of value.
Yeah, so just wanted to add that like in COVID era, actually we have seen like many inflammatory markers to assess like the CRP, LDH, serum ferritin, D-dimers. A lot of things that we have used in assessing that. But ultimately, for sepsis, a lot of studies have been done in last 20 to 25 years, and we found the very specific markers, the lactate in fact. So, and why we chosen this task also, because like many of the ABG machine itself shows the lactate levels. So when we do that serum ABG, and so automatically we get the lactate, and if it is not there, then we can send the sample for that also, and we can get it, and we get a very good idea which should be like Dr. Saif told about this 1 hour bundle and all. So that is a very ideal time to take care for the patient. And why it is important for the nurses also, because nurses are the key holder at the bedside. Because like we being a doctor, many times we come for the less time, but nurses are there continuous for 6 to 8 hours there. So they should also know, and that shows the concern to the nurses, and accordingly they can deal immediately better for the betterment of the patient. Thank you.
Definitely, definitely. Totally, I agree with you, Dr. Joshi, that nurses and technicians, if the technicians are in your ICU, they are very, very important workforce, apart from residents, of course, I mean, the doctors, but nurses are really, they should know more and more. And that is why these programs are being conducted, and I'm very, very happy about it. Yeah. Any other question?
Yeah. Okay, so because no questions are there, I just wanted to ask a few questions in relation to the audience benefit is that everybody is having the question that which antibiotics to be started with when the patient comes to your hospital. The hospital can be at Ranchi, hospital can be at Indore, and hospital can be at Mumbai, Pune, anywhere. So the queries are there which antibiotics to be started with. So what's your answer?
Yeah, thank you so much for asking this question. So the antibiotic depends on the local antibiogram, so your organism, because your ICU, you should know what organisms are prevalent in your ICU. This is one. That is environment, which you should know. So from microbiology lab, you can get an antibiogram and then see what are the organisms are there and what is the resistance pattern. So based on that, you should select your antibiotic. Second thing is that what infection patient has, what focus of infection. That is also very important. The nature of infection. And third thing is the host, whether the host is immunocompromised, having the comorbidities, or age of the host, and the other factors in the host. So that is also very important. So these three, based on these three things, principally we choose the antibiotic. So for example, if the patient is coming fresh from the community, with respiratory symptoms, okay, fever, cough, and desaturation. Then we suspect pneumonia, we take a chest x-ray, we found the obesity. We should start the antibiotic. Now, because the patient is coming freshly from the community, then we should start a very mild antibiotic. We can just start augmenting. That is the amoxicillin clavulanic acid combination. That will be more than sufficient, or even levofloxacin is good. Okay. So if the patient is coming from some other hospital, spent time already more than 5 days in another hospital and referred to your hospital, definitely you should think of higher grade antibiotic. Okay, because you have to cover the resistant organisms. In that case, you can start a little bit higher, like piperacillin tazobactam. Okay, or if you think that patient has already received the piperacillin tazobactam, that is also important. You have to see the treatment part as well, whether the patient has received, which antibiotic patient has received in the previous admission. So then you have to go for a little bit higher grade based on procalcitonin value. So that is about the antibiotic. It is a big topic, so I think it can be covered in other sessions.
Yeah, just wanted to add that, like Dr. Saif told, that is basically question was asked to make everybody attentive in a phase that in every ICU is having different flora, every city is having different flora, and according to that antibiogram, you should choose that instead of going for the right from the international guidelines. So local guidelines should be made, can be made for that antibiogram accordingly. Some questions came from the audience that in echo, ejection fraction is 40%. So can we start with the large fluid management?
Ejection fraction 40%. Why not? Why not? We can start, but not large fluid. If the cardiac there, so 40% means that there is a little bit of cardiac dysfunction. It could be just because of fluid deficit also. The preload is not good. So if you give little bit fluid challenge, okay, or you can give auto that is called auto fluid challenge or leg raising test, you can do that and see if the ejection fraction or stroke volume, specifically stroke volume, is increasing or not. If it is increasing, until the point it is increasing, you can continue fluid. So there is no concept of large fluid in case of cardiac dysfunction. You have to keep the small aliquot of fluids and see the stroke volume and ejection fraction.
Another question was there in the chat box. Is was like if any guideline changes are differences in guidelines for postpartum sepsis.
Postpartum sepsis. Oh, I don't think. In postpartum sepsis, it is again a sepsis, okay? That the focus of infection here is in the either uterus, or it may be a suture line, or it could be in the cervix. So some infectious focus is there in the uterus. So that has to be looked for in ultrasound, and that has to be removed as soon as possible in the postpartum sepsis and septic shock. And regarding the antibiotic, already I've said fluid will be the same. Antibiotic has to be decided covering the gynecology.
So I think that take-home message again to assist that patient first, just for the sepsis. If sepsis is there, 1 hour bundle everybody should follow, and in your hospital if it is not following, then please guide other nurses and doctor to follow that. And you, after many patients, like maybe once you do the process for almost 20 to 25 patient and then they survive, it will give real benefit to your soul that you have did something good for the survival. Because till date, whatever we do in the medical field, either it is by doctors or by nurses or as a whole by team, when patient survives and goes home by routine discharge, then that the satisfaction which we get, you cannot get with any amount of money. So my suggestion is there, please follow all this. We'll meet again. Thank you very much, Dr. Saif,